Thank you so much, Dr. Sharma, for that inspiring message. I think you've struck the right chord to resume our panel. I would request you to, I would now like to welcome other panelists. Pradipta Kundu, Director, Health Mission at the eGov Foundation. Sean Blash, Co-founder and UNICEF Coordinator, Digital Health Center of Excellence. Venkat Subramaniam, Senior Project Manager at Google Research. HSD Srinivas, Project Director, Health Systems, Tata Trust. This discussion will be moderated by M. Harimenon, Director of the India Country Office at the Bill and Melinda Gates Foundation.
Good afternoon and welcome to the post-lunch session. It's never easy being the first panel after lunch, and digital health might not be the most exciting of topics for many of you in the room, but in many ways is actually one of the most critical applications in terms of the potential for digital technologies to touch the lives of people. And today we have a fantastic panel here. You already heard from Dr. Sharma. What we're going to hope to discuss over the next 40 minutes or so is just get perspectives on how digital transformation that we are seeing can potentially provide a pathway for the sustainable delivery of health. I think we might almost have a question mark at the end of that white line, which is digital health solutions. Road to sustainable healthcare delivery, it almost reads like a statement, but I think a better way to do that would be to have a question mark, because a lot needs to be taken care of before you can actually have sustainable healthcare delivery through digital. So we have 5 speakers. We'll probably do a couple of rounds of questions, and if we have any time at the end before 3:20, we might go to the audience, but I'm told we have a hard stop at 3:20. So, Sean, maybe to kick things off, going to that question mark part of digital and sustainable healthcare delivery. During COVID, there was a lot of, I would say, attention paid to the importance of digital health for a variety of reasons. You were actively involved in supporting many countries, particularly in Africa, to adopt, embed digital solutions. From your perspective, for LMIC countries, given there are multiple trade-offs to be made in terms of where they should put their money to strengthen healthcare, what's your perspective on what do countries need to have in place to actually make a go of sustainable healthcare delivery with digital health?
Great question to kick things off. So I think to start, governments really need to have a clear vision, and it needs to be patient-centric. It needs to speak to health outcomes, not technology outcomes, and have in place the structures required to successfully implement. We've seen several good examples in LMICs, particularly during COVID, and several bad examples of countries that applied inappropriate solutions, top-down solutions, or initiatives that were really focused on the needs of national stakeholders and not on the clients seeking health services. I think one of the examples that I like best is from Rwanda. And I would note that most of the successful examples came from countries that were investing in resilient systems prior to the pandemic. Countries that rushed out COVID-specific electronic immunization registries, certificates, without a strong foundation, often struggled and will continue to struggle as they reintegrate these platforms into routine systems. But in Rwanda, and taking us back to the session before lunch, had been investing in digital identity and CRVS reform prior to the COVID outbreak. They brought birth registration services directly to health facilities. They eliminated multiple steps. To the panel or to the audience member who talked about applying technology on broken systems, Rwanda optimized their processes. And as a result of this, before COVID hit, Rwanda shot to the top in Africa in terms of birth registration and national identity. Today, Rwanda has about, I believe, an 84% birth registration rate, which for the continent is incredible. Now, how did this actually apply during COVID? Well, Rwanda had that national identity program in place with solid coverage. In terms of vaccine services, they took an existing platform, DHIS2. They didn't try to create something new. They weren't wowed by fancy solutions coming from the global north. They took something that had been proven to work, and they expanded that for COVID, and they embedded that within the country's existing health processes. As a result of this, when a mother goes and gives birth at a facility, she can get her birth certificate almost instantaneously. That ID, which is issued on the spot, gets plugged right into a facility electronic medical record. It's linked to their community-based health insurance scheme, and from top to bottom, services are tracked, quality of care is measured. And for COVID, now very different population, but the adult population as a result of these investments, at least as of September, 77% immunization rate, which beat the target of 70%. I think they're one of only 2 countries in Africa that hit the target. And so, I would just conclude with saying to reach strong health outcomes, you really need to be thinking about the entire ecosystem. You need, again, that government leadership and vision, short-term rush solutions focused on individual diseases or verticals tend to not work, and investment ahead of time in resilient systems pays benefits during situations like the COVID pandemic.
No, thanks a lot, Sean. Very valuable lessons there. I know one of the sub-themes we are supposed to talk about today is, interoperability and how that's going to enable data flows across countries. But coming to you, Dr. Sharma, let's forget about countries. Right now, one of the biggest challenges in a country like India is how do you even just get data to flow across the public and private sectors, right? So as you envision the rollout of ABDM, how do you see, ABDM offering or creating, an incentive or adoption structure for, public and private providers of health to come together on one platform? Because you've often spoken of, the value proposition to, Indian citizens would be, having this unified healthcare experience regardless of, which provider you choose.
I think that's a very relevant, very, very important question. The architecture which I spoke about, the framework which I spoke about, actually is just a framework. It does not distinguish whether the participant is a private sector provider or a public sector provider. In fact, citizen it is at the focus of this framework, and ultimately he or she is the person who is the most important stakeholder. Others are either service providers or payers for his treatment, or he himself or pays. So essentially the architecture which is being built is based on the principle of interoperability, openness, open standards. So what you do is you just can plug in. So for example, unified health interface which I spoke about, now essentially that is also a set of protocols. ultimately UPI, what is UPI? UPI is nothing but a set of protocols. It's actually a language of money transfer. If, I can use a very common sort of sentence. Similarly, UHI is actually a language of health-related information interchange. So that's what it should be understood. And they are typically in a what is called the platform architecture. There, everybody has got to be on the same platform. So, for example, if you are on Amazon, if you are buying something on Amazon, you have to be having an Amazon compatible application with you. You have to interact with the sellers on Amazon. Right. You have to pay through Amazon. That's the architecture, the platform architecture. We have gone beyond that. We are basically creating what is called a network architecture. And in the network architecture, you don't have one-to-one communication. You have the adapters or the protocols which are open to anybody who follows those protocols. So essentially, you just become a part of that network and you are very much there in that ecosystem. So that's the real value proposition, and that proposition is applicable for anybody, whether a private sector, public sector, provider of ambulances, provider of medicines, the pharmacy, or any person in the healthcare ecosystem is actually becomes a part of that UHI. Similarly, what we are building is another interoperable important structure, is that today we have a very underdeveloped insurance market in this country. Of course, we have provided the insurance to 500 million people under the PMJY, but if you think of real insurance which people, middle class or upper middle class people take, those insurances, hardly 5 to 7% people are having those kinds of insurances, private sector insurances. And what is happening is that today we don't have the OPD-rated insurance. You have insurance for serious diseases. We have built what is called the health claims exchange. That exchange again, simplifies the whole process of provider-side claim submission, payer-side payments, and it goes through the same pipe which actually follows a very standard architecture and standard protocol. So our job is really not to, as he very rightly mentioned, it's not technology. Technology is merely an enabler. Ultimately, we must enable services to be delivered in a more effective, more efficient, more affordable manner. And that's what we are cognizant of this fact. It's not technology, just a means to achieve an end of universal health care. And that's what we are doing. And I think the best way for a country as diverse as India, 1.3 billion people, 26 languages, and there are hundreds of dialects. And if you are developing an application for this country, you need to develop, more or less you are developing for the whole world. Right. It's 1/6 of the humanity. And therefore, I think the only way you can actually develop a successful digital intervention, that is through having a completely open, interoperable, and scalable architecture.
No, absolutely. Thank you, sir. So actually, I'm going to use Srinivas because as Dr. Sharma mentioned, ultimately the architecture is only as useful as the solutions that ride on top of it and that actually enable better delivery. The Tata Trusts have, of course, been engaged for several decades in improving, delivery and access to quality healthcare with a particular emphasis on primary care. So, as a user, so to speak, of digital health technologies, what are your perspectives on one? How does ABDM potentially, change the game for you? And what are some of the lessons that, Tata Trusts have from your work in rolling out innovative digital health solutions?
Thanks, Hari. ABDM is a very exciting development for us, as it is for, for the entire country. We have long back tried out multiple digital interventions, whatever applications that have come together in small POCs. Unfortunately, while we could demonstrate the success of say telemedicine or a electronic health record or a voice to text kind of software applications, all towards ensuring better efficiencies in healthcare delivery, we could not, to the extent we wanted, could not scale these up because of, again, the multiplicity of the applications that are floating around, and governments reluctant to add more clutter. But with platforms now, the standards being specified and an effort being done through a mission mode, we hope that some of these applications, we would have a more integrated platforms approach, particularly for preventive care and primary care. Now, most of the applications have been developed for the tertiary care. Our effort is that if we can actually identify and screen diseases in the community and manage as much, all the chronic diseases within the community, then you can regulate the flow to the higher institutions and thereby actually save a lot more pain and surprises for the patients. So I guess, so we are really looking forward to having this kind of, a standardized platforms being used, and that will help us, in really faster scale up of all the POCs.
Yeah, thanks, Srinivas. So you spoke of primary healthcare, and Venkat, coming to you next. I wanted to speak a bit about the application to public health. I mean, again, COVID focused everyone's attentions on the gaps in country systems, be it integrated surveillance, data sharing across different layers. Google Health's focus is, of course, on cutting edge technologies, AI, and you're using it to solve a variety of health challenges, cancer detection, TB screening, detecting blindness, etc. What are some of your thoughts on how the work that you're doing and cutting edge technologies can be used to improve public health, and where do you see opportunity both for India and other countries in the global south?
I can answer that for 10 minutes or for 10 days. I'm extremely passionate about this topic as such. First, let me start off with the ABDM thing, that, and probably from a macro, and then go down to the level of the AI applications. The closest analogy that I can think of is the Cambrian evolution, the Cambrian explosion that happened 500 million years ago. Suddenly, on the face of the planet, there was a plethora of species that came up. In India, that's the opportunity that stays. So the sustainability question, the way you started off, that's what I'm trying to answer at Google as well. We at Google Health Research, we are trying to answer what exactly the fundamental pieces are. And like the way for the Cambrian explosion to happen, you needed oxygen. Ozone was not there before. There were single-celled animals. And suddenly you have all these multi-celled animals, etc., come up. In India, in healthcare, this is what is going to happen, right? With ABDM, that's the first approach. The policy is in the right direction. The building blocks from the government side is coming up. We at Google Health, we are thinking along these on multiple vectors. First thing is that Professor R. Sharma said about building blocks. Okay, you build the building blocks, but for someone to go and create an economic incentive out of it, you need a little bit more meta between that. So we are creating a set of open source components, open source, open standards, secured by default, and lots of other things. So how do you lower the cost of ownership by accelerating your time to market as well? So I'm happy to share that we have an open source project called Android Fire SDK, FHIR. It's a standard in the healthcare industry that got just adopted as a DPG last week as we speak. And this is just the first step towards enabling this ecosystem in India and overall in global world as well. And interoperability that Sharma said, beautiful, right? Interoperability is a problem because when you think of digitization or digital transformation, the first step is you need to, digitization, etc. I said all those things, but what is the problem there? Each silo exists because silos are extremely effective, right? Solving the silo problem is a mundane, it's a moot problem, right? We should not try to solve it. That's why the federated architecture comes in. There is a decentralized system, you're bringing the systems together. Amazing value prop there, right? But security challenges, security, privacy, consent. We are thinking about differential privacy there as a construct. At a large organization, when you are storing so much data, what does this mean for private entities and for public entities, right? Developers, so finally, some of these digital has to be developed by a developer, right? How do you make sure that he goes and sleeps, has a good sleep? Right? So those are, as a product manager, I can talk about this for hours and hours, but solving those problems. Okay, all those is good. Next, AI and data, extremely important pieces. So This is the mundane stuff, right? As in, we have to do this to even enable it. The approach that we are talking before even going to AI data is, how do we let the public health workers make better decisions at point of care, at point of service? Community healthcare worker, even administrators, personas as part of the value chain. Okay, so we are creating all mobile applications that partners can go and create all these things. Now, data. Sir said about FHIR and interoperability. You can put all the data in systems that you want. Unless you go and query it, it's a problematic thing. You can keep on dumping data quite a lot. So we have created a system by which we have lowered the cost of accessing data, creating insights using FHIR analytics. Okay. Now comes the interesting pieces. So data, you can put data, you can consume data, AI. As you said, we have done some amazing work. For us, our primary interface is phone. For a country like India, how do you democratize access, right? It sounds like an interesting problem, but what is the surface that we want to provide this delivery to? How do we enable the last mile worker or the first mile worker to take some of these technologies, do some screening at the point of care, or relay it back to the PHC and do effective decision making? So integration challenges there. So our AI models on the eye, using phone, just using cough, can you identify TB? For a country like India, if you have to run a tuberculosis screening, you can imagine the cost. If you have to go and deploy 1 million healthcare workers, it's non-trivial. These are the problems that we want to solve with Google, right? So we are just getting started. As part of this, we are creating this open source set of components. You will hear a lot about this as well, essentially solving different personas problem, and as well as how do we enable our healthcare workers, our public health systems in India as such, to take some of these screening technologies at scale. And the question of health outcome, the problem in some of these things is health outcome has not been defined yet. What exactly does health outcome mean? I was selling software for 20 years. You have a revenue target, you go and chase it. Health outcome, okay, what does it mean? So probably the morbidity, mortality rates, defining it in a slightly structured way. Probably start off with small silos, create the interoperable architecture, latch on to things like ABDM, which are policy-based decisions, and then, it's an ecosystem play, it's a long-term play. Can this be India to the world story? Is that question that we have to ask ourselves.
Yeah, no, thanks, Venkat. Pradipta, coming to you now, you've spent, most of your career working on open source technologies and, applications in health also for a while. So Dr. Sharma spoke about CoWIN, which was obviously a massive success for India. And E-Government Foundation was one of the partners who contributed to that. So open source doesn't guarantee any of what we are talking about, right? Scalability, interoperability, none of that. So when you were actually looking at CoWIN and designing it for the world, because that was the Prime Minister's the proposition he laid out was, whatever we develop should be for the world. So what were some of the considerations that went into designing CoWIN in that way? And then I have another question for you after you answer this on, open source, that ecosystem and, how it needs to be supported. So,
so when we partnered on a piece of CoWIN, which is the DIVOC, which is where the verifiable certificate that we all have in our pockets. And when when you build anything for India, you have to think about scale. You cannot ignore scale. And this was a campaign that was going to be rolled out at massive scale, never done anywhere ever, right? Because we were not going to be targeting, children under 5, but everybody else, in a way. So we had to start thinking scale upfront. But also, one of the things that's really very part of our DNA is that we need to make these systems interoperable from day one. Because when we rolled out our system in 5 countries, within a period of 6 weeks, we had to integrate with different systems, and we were able to do that because we were open APIs right from the beginning. The third thing I think that really helped is we were part of one of the contributors to defining the standard for the certificate. We were part of the WHO panel. And I think that was also a trust building sort of exercise, because when we were standard compliant from the very beginning, that was sort of, actually, I think Dr. Sharma can talk to this, that I think because our certificates were WHO DDCC compliant from the very beginning, we were able to get bilateral agreements with over, Dr. Sharma, 90 plus countries without any hiccups. So those are some of the enablers that, and things that we thought about from day one. So standards are important, APIs are extremely critical, and in a country like India, you cannot not think about scale.
So actually, I'm going to switch to Sean for a second and then come back to you. So Sean, you heard Pradipta's point about designing for scale, designing for interoperability, because you work across multiple countries. India feels like a continent, but eventually, I mean, we are a country ultimately, so it's easier to standardize across the states and think of adoption in a more cohesive way. When you look across particularly sub-Saharan Africa, and that's where a lot of people are thinking about when they talk about the future of digital health transformation, what do you see as some of the biggest challenges to this notion of interoperability and scale?
So again, going back to that leadership, the vision that India has demonstrated, I think is absolutely critical. This is not just a technical exercise. The standards around exchanging patient data like FHIR, health information exchange, architectures are pretty well known at this stage, or at least the best practices are. The challenge, and again, I think previous sessions have identified this, is both in ensuring compliance, making sure that not only do you have a well-articulated digital health blueprint, but you have government mechanisms to ensure that the public sector, the private sector align to it. You need the right kind of incentives to bring in the private sector. Much of healthcare in Africa is not government run, it's private sector run. So how do you bring them in as a solution and not just a challenge? And so without this in place, the best standards, the best applications in the world are going to end up sitting on a shelf somewhere. And we often see this actually in terms of interoperability. I think one of the things that I would notice that there's often a misunderstanding between integration and interoperability. When people talk about interoperability, they often only mean how can I connect system A with system B, rather than how could I put together this framework that allows any standards-based solution to plug in. Interoperability is expensive upfront. Integration's cheap. But as systems get more and more complex, integration becomes very expensive, and interoperability suddenly has solid return on investment.
So that's a great point. I know, we're not a technical discussion here, but the point you just made, I think that's something that doesn't often factor into, design considerations or even funding decisions by governments and donors. But a key takeaway for us from this session. So we have about 10 minutes left, so I think maybe we can swing in 2-3 more questions. Going back to you, Pradipta, a lot of what we heard from Dr. Sharma about India's vision for ABDM, a lot of what Sean spoke about, what Africa needs is open source technologies, because there are definitely cost and other efficiencies to building out public digital platforms, including in health, using those technologies. But the open source ecosystem, as someone said in the morning, is not a cost-free ecosystem. I mean, there are costs, there are more reasonable costs, but there's definitely a need. So from your perspective, what are the challenges that you face, to make sure there is a sustainable ecosystem of providers active in open source? Because I think that's something that, the minute you sign up to a proprietary platform, the commercials are taken care of for you. So sitting on the other side of the fence, what are some of your asks, some of your considerations that countries and donors, including philanthropy, should think about?
Yeah, and that's a very good question. And, I love having this platform because we are the developers on the side. What do developers need, right? And to be honest, e-government foundation is a relatively better funded philanthropic organization. I worked at smaller firm or organizations, again, open source. So, most often, when we talk about open source, the intent of open source was free as in freedom. But it has come to mean free as in free lunch, right? And free lunch does not last, right? And what typically happens is, where does the funding go, right? The funding goes in the implementation of that technology. Like we heard in the morning where people talked about, we're able to deploy solutions because now they're open source at very small costs, right? That's the power of open source. You can distribute widely and scale up at very reasonable cost. But there is not yet a model where the developers of those technologies can be funded. What gets funded are the people who provide the services on top of that technology. Most open source technologies in the world struggle to fund its core, right? And I think the best model that is out there is the Linux Foundation, which has managed to provide a stable home for all the technology products and able to get funding. And I think maybe we should start looking at some of that. I recently came across another organization in the UK, which is actually being funded by NHS. Which actually is promoting and providing that custodian for open source technologies in health. So I feel like a vehicle like that will provide that stable funding for open source organizations is very much required. The world is powered by open source, whether it's Android and more in digital health. So I think that a time is coming when we will require that kind of a custodian to provide that stable funding.
Thanks, Pradipta. I was listening, and I hope so were others in the room about the things we should do to make sure there's a sustainable ecosystem. Sir, coming back to you, I think no talk of digital health is complete if one doesn't talk about security. Even in the morning, a lot of the conversations about digital ID and digital public goods were about the important considerations related to security. Now, with the vision of ABDM, there's the likelihood that more and more providers come in to build the applications that are needed for this ecosystem to thrive. That means there will be many entities, whether public or not-for-profit, who will be storing or at least recording patient data. So from your perspective, as you look at this ecosystem, as this future possibility, what are some of the safeguards and mechanisms that you're putting in place and that others should be thinking about to ensure integrity, security of data? There was this recent story about, I think, Australia's health database was breached, and a lot of that is now being sold on the dark web, etc. So how do we plan for this future?
I think security today is a bit of a distributed stuff. So for example, what has happened is that when you store the data on the cloud also has a layer of security. As I explained in the beginning, we are not the ones who are storing the data. The real data is lying with the Max Hospital or Apollo Hospital or the district hospital, wherever it is. We are not really storing that. So obviously the guys who are storing the data, patient's data, they are responsible and they are liable for the security of that data. And basically we are not creating any ambiguity in the sense that if data was stored with NHA also, then you would never know as to where from this data has been leaked or hacked. We are very clear that we are not storing the data. What we are, however, storing is the link. And that link has to be absolutely secure. So that part, I think we are taking care of. Of course, there are multiple mechanisms. One, no data in our kind of cloud is kept without encryption. This has been the policy in Aadhaar. This has been the policy throughout whatever digital public goods we have made. No data. For example, it has been about 12 years since Aadhaar was, 29th of September 2010 is the first Aadhaar was issued. It has been 10 years. Not even a single record has been hacked, leaked, breached from Aadhaar's database. Of course, touch wood. But it is not as if, we are not having security through obscurity. We are just saying that, we are restoring. We have very clear mechanisms as to how we can ensure multiple layers of security. So that part, I think we are very clear, and we will continue to strive. Obviously, security is not a static stuff. People also keep on developing the breaches for the security, then you build another layer, and that's what you keep on doing. So that's the broad kind of strategy of ensuring security of the data. Privacy, I have already answered. One thing which I wanted to add was very interesting. People generally think, a layman or a illiterate person or a person, he'll say, what is the use of my longitudinal health record? What is this animal? So essentially we have created some very, very interesting use cases. So one of the use cases which we are experimenting since last about a month or so is what is called scan and share. And I think tomorrow when you have this discussion, probably my people will be able to show you. The idea is very simple. People stand in line in the AIMS for 8 hours, starting at 4 in the morning until 12. And they just wait for an OPD slip. Now, essentially what we are saying is that you already have your Ayushman Bharat Health account. That has a QR code. You can, and the hospital also can put up a QR code. You scan that hospital QR code and you can transfer your personal profile to that HMIS of the hospital. Hospital HMIS can issue a token number to you, and you just keep on sitting with the token number, and when your token number comes, you can just get an OPD. So you don't have to stand in the line. Now, you'll be surprised to know we started this about a month back in the Lady Harding Medical College here in Delhi, then of course in Bangalore in C.V. Raman Hospital, and then we started in Charak Palika Hospital here. Today we are having about 25,000 people using this system, scan and share. And basically it provides a huge convenience to people. And it's a very simple thought. I mean, there's nothing, rocket science about it. You pay your, Paytm fellows, or you pay all these fellows on the Thela Wala, you just got kind of scan it, and then you put in the amount and it's done in the UPI. Similarly, you just scan the thing and you transfer your information and you get registered there as a patient, and then you get a OPD slip printed. In fact, you can have kiosks in the hospital where you can probably self-print your OPD slip. That also can happen tomorrow. So essentially, these are the use cases which will slowly come and which will create an interest, and adoption will take place, because adoption is a big challenge. Aadhaar was a simple project to do because there were only two stakeholders in fact. The citizen who was interested in getting an identity, the government who was interested in giving them identity, and of course funding the identity provision. Here you have laboratories, the hospitals, the doctors, the patient, n number of these guys. And therefore it's very important that all these stakeholders have enough interest in that system. So that's that I wanted to share with you.
Thanks a lot, sir. So I think we have about maybe 3-4 minutes. So maybe that's time for just 2 questions from the audience, and then we'll wrap up. Yeah, if you can step up to the mic closest to you and identify yourself. So start with the gentleman wearing the hat, and then next to you, sir.
My name is Arnab. The question could be taken either by Pradipta or Mr. Kundu or Mr. Sharma. You spoke of the government's insurance scheme in the health. I would just like to understand, do you have a standard policy for fraud prevention in that? If yes, could you please elaborate? That's what. Thank you.
Okay. Yeah, I think that's a very interesting question, because we are processing about 1 million claims per month in PMJY. And we are processing another, 300,000 claims in the CGHS. And we have a number of other kind of schemes also. They are not necessarily insurance schemes. They are also trust model, whereby the states are paying money from their, budgetary funds. And we have put in a very robust, anti-fraud prevention system in place. So, for example, there are rules, fraud rules. So, suppose I got my kidneys, kind of transplanted. Now I've got 2 kidneys only, 2 only can be transplanted. If the same fellow comes for a 3rd kidney transplant, obviously we'll say this is bogus. There are many procedures which are done once in a lifetime. Now, if the fellow comes again, then again we know. So essentially these are the triggers which are triggered, and immediately when a trigger is triggered, then we put it into the NAFU bucket, as it is called, National Anti-Fraud Unit bucket, and then that is examined and that basically is investigated. So we have a very robust fraud prevention mechanism, and we are effectively able to kind of catch most of the things. We don't really know as to how many are left out, that I must be honest with you, but I think we are able to very effectively, because we keep on developing those triggers also, because the fraudulent characters keep on coming with new techniques, and we also have to kind of follow them.
Just one thing, sir. The reason why I asked this question was we have a fraud analytics product in the supply chain space. Would love to speak with you after this.
Okay,
if we can take it into
which
the
is not
insurance.
allowed, yeah?
Thank you.
Okay. Coming to you, sir.
Yeah, my name is Boon Chai. I'm from Asia eHealth Information Network. Thank you for the framework of the India. It's a model for many countries. My question is that we know that frameworks, interoperability is very important and it's foundation. But easy to say, but difficult to implement or adopt. I wonder that how India have the frameworks or the plan for the incentivized many stakeholders that have a different conflict, maybe have conflict of interest, to adopt the standard or the framework or the architecture that you're laying down. Thank you.
Yeah, thank you for that question. I think it's very, very important, because adoption of the interoperable framework is very important. And I'll like to go back to Son, who made a very interesting distinction. It is not integration. It's actually creating that APIs, the adapters, which will basically make you a part of that ecosystem. So essentially what happens is, when I am serving my own, the customers, which are just, which are using the same platform, where the doctor is using the same and the patient is using the same video consultation application, then my space is limited only to my customers. Once I become a part of a larger ecosystem, then the entire, set of customers are my customers in some sense. What I need to do, we are not really getting into the question of, that every application has to be developed afresh. We realize that there will be large number of silo applications, no problems at all. What you need to create is create an adapter in front of those applications, so that you become a part, you are able to participate in that entire ecosystem. So it's very easy. So first of all, the incentive is for the application makers and the ecosystem partners to basically increase their customer base. If it is only a silo application, your customers will be limited. Now, if it is interoperable, then the entire world is your customer, and then whosoever is the most efficient will be able to be the winner in that sense. Not that it will be different. It will not be the IT kind of platform type of situation where winner takes all, where you only have Facebook, you only have Twitter, you only have, of course, Google. I will not say. But this is actually, this winner takes all situation is avoided because of the fact that the entry barriers are lowered considerably. That's how it happens.
Thank you so much. So with that, we are out of time. So I'll skip the customary wrap-up, etc. Safe to say, very interesting discussion. Thanks to the panel. There are many important questions that remain to be answered, both in terms of India's adoption journey, as well as the broader questions about, how do you get data to start flowing across country boundaries, etc. But this will be an important theme in India's G20 presidency as well. So hopefully there will be interesting conversations and solutions over the course of this year. So thank you so much, the panel.